Today, I'm going to walk you through the hype behind data science in healthcare, and then we'll talk about what the reality is really like, and then we'll dive into some solutions that my team has come up with to try to navigate healthcare, or data science in healthcare, and then we'll speculate about maybe some future directions of data science in healthcare. So before I start, is there anyone in the room that works at IBM? Okay. Well, I'm going to apologize in advance if I offend anyone. So let's get started with the hype. So I'm going to go through some headlines here. IBM Watson is better at diagnosing cancer than human doctors. So this is from 2013. And IBM Watson may provide a shortcut to treating cancer. And then here's another person you might be familiar with in the machine learning or deep learning space. Here's a quote from Jeffrey Hinton. "We should stop training radiologists right now. In 5 years, deep learning will have better performance." And that was in 2016, so we're a little more than 2 years in now. And Andrew Ng, he said, in relation to some work that his group was doing at Stanford, "Should radiologists be worried about their jobs? Breaking news. We can now diagnose pneumonia from chest x-rays better than radiologists." All right, so let's talk a little bit about the reality. So this is more recent news. Watson can't cure cancer, or all the stuff that breaks IT projects. University spends $62 million on AI trial, gets usual trials that come with failure. I actually think in the end, it actually ended up being more than $62 million that they spent on that project. Some cancer treatment recommendations from IBM Watson were unsafe, report fines. And then talking about replacing radiologists, this is from a radiologist slash machine learning researcher. I've spent several weeks exploring the chest x-ray data set, and I have some serious concerns with it. So that's the data set that was used by Andrew Ng's group. And he followed up with, "The data set as defined currently is not fit for training medical systems." And then there was this other doctor who is also doing similar research. He said, "Now today, more comes from the Stanford group. Guess what? The deep learning method sucks. It's much worse than the radiologist. No way Andrew Ng is trusting his own diagnosis to this algorithm." And this is actually like the published results from the Stanford group, and it shows, if you look at the bottom line there, the overall performance of the model is worse than the radiologist that they tested it against. And he says, "You know what else sucks? When high-profile machine learning people oversell their results to the public, it leaves everyone worse off, because how can us mere mortals publish a paper if we haven't rendered an entire profession obsolete with our results?" So some of you may be familiar with this XKCD. "Our field has been struggling with this problem for years. Struggle no more. I'm here with algorithms." Wow, this is a really hard problem. So moving right along to the reality. So this is another vocal doctor on Twitter, Eric Topol. He said he did an analysis, a summary of 12 papers, and he pointed out that all of them are retrospective. Some of them have statistical methodological issues, and we've yet to see prospective validation studies in the real world clinical environment. So this is kind of an important point he's making. A lot of these papers haven't really been tested in the real world to see if they actually perform the way that they claim to perform. And here's another tweet from him. "The first FDA-approved device to diagnose diabetic retinopathy without ophthalmologists, with no published data. And they make some claims on their website about the performance of the model, but there's really no way of verifying it. Another common issue in healthcare, this is an article written in the New York Times recently about doctor burnout. More than 50, so in the article they say more than 50% of physicians in the United States have at least one symptom of burnout. And they point out that the EHR has become the electronic medical record, electronic health record has become the symbol of burnout. So speaking, a little bit just about electronic health records, they're designed to replace paper records, and they're designed very much just like the paper records for focusing on billing purposes. And at least in my opinion, not enough thought has really been given into how computers can help improve things. They're often one-to-one mappings to the existing paper systems. And as someone who has to utilize these enterprise clinical databases, I find the design of the database is awfully complicated. There's a lot of empty, unused, or seldom used tables in these databases, and there's often no real clear guidance on what particular tables are used for. The databases are not append only, which means values get overwritten. So there's also often no indication of when a value was written. So there's really no way that you can use these clinical database systems to reproduce what did the patient look like at any given time. And then there's some interesting, messy human data issues. So what would you expect to see if you were looking at a temperature field in a medical record? Probably, temperature in Fahrenheit, maybe the patient's temperature in Celsius, maybe something about how the temperature was collected. You can collect temperature in various ways. This is the type of thing that you can find in the temperature field in the medical record. Unable to take temperature, patient just ate ice. Or patient feeling hot, like I have a fever, deferred temperature reassessment. Patient recently sipped water ice water. So you might just think, okay, let's just throw out this weird data, but that may actually not be the right solution, because a patient chewing on ice actually could indicate that they have a form of anemia. So it's not always obvious what to do with this weird, messy human data. All right, so let's dig into some of the solutions that my team has come up with to deal with a lot of these issues. So when I first joined the team a few years ago, we actually were housed in a startup space, and there was a startup sharing this space with us called Active Protect, and they developed this device, which is a belt that elderly people can wear, and it has these airbags built in to prevent them from breaking their hips. So you can see, here's a demonstration by one of the founders of the belt in action. He's falling over, the airbag deploys, and so he doesn't break his hip. And so we were, as a team, we were thinking about one of the projects that we were currently working on, which was trying to predict patients that would develop sepsis, which is a type of severe infection. And we were thinking about how, wouldn't it be great if this sepsis problem was more like this airbag problem? In the airbag problem, it's a completely observable system. So what I mean by that is the device makes some prediction about whether the patient is going to fall or not, and then the device, if it thinks that the patient is going to fall, it deploys. Deploying of the airbags presumably does not like cause the patient to fall, and so it doesn't impact the actual outcome of whether they fall or whether they don't fall. Whereas the sepsis problem that we were working with, we're trying to predict what patients were going to get this severe kind of infection so that we could prevent them from getting the infection. And the issues that we discovered with this is that it made it very hard for us to tell when the system was not performing the way that we expected it to perform. Was it the model, or was it the intervention, or was it something else? Because we had this unobservable system where we were impacting our model was impacting the outcome, our use of the model was impacting the outcome, we couldn't tell where things were going wrong. So we use this like terminology commonly. Is it an airbag problem, or is it a jetpack problem? Where the sepsis example was a jetpack problem. So is your solution an airbag or a jetpack? And can you like rethink the design of your system to design it as an airbag instead of a jetpack? So in the case of like IBM Watson's example, how can they tell if they're giving the patients the correct treatment? If they're trying to use the model to improve patient survival, how can they tell if the model is wrong, or if there's something else wrong with the system that their model is integrated into, or the intervention? So is this a good model? How about this? This is a confusion matrix taken from this model. So for those of you who aren't familiar with a confusion matrix, in the upper left-hand corner, that's your true negatives. And then in the upper right-hand corner, that's your false positives. In the lower left-hand corner is your false negatives. In the lower right-hand corner is your true positives. How can we tell if this is a good model? If I deploy this into the healthcare system, how can I tell if this model is going to have a positive benefit? So when outcomes are uncertain, the best decision is the one that has the highest expected goodness. So expected goodness is the sum of the probability of an outcome times the goodness of an outcome. So how do we measure the goodness of an outcome? So we can develop these cost matrices. So again, in the upper left-hand corner is the true negatives. So the cost of a true negative is, in this example, is 0. And then we have our false positives. So if you have a false positive, you're going to apply some intervention to your patient that they didn't actually need. So the cost of that decision is the cost of the intervention. In the lower left-hand corner, we have our false negatives. Those are patients that you should have applied the intervention to, but your algorithm did not pick them up. So that's the cost of the negative event. And then you have in your lower right-hand corner your true positives, and the cost is the cost of the intervention plus 1 minus E times the cost of the event. And so E in this case is the efficacy of the intervention, because you have to assume that sometimes your intervention is not going to work for a patient. And so applying this kind of decision theory, we can frame our predictive models and in a way that allows us to determine if we deployed this to the health system, would we expect it to have a positive impact? So in this visualization, you can see on the x-axis is the cost of the event. And there's some uncertainty around what the cost of the event is. There's also some uncertainty around the cost of the intervention, which is what is on the y-axis. And we can see that in the upper left-hand corner, this whole black region of the space, that's the region of the space where it doesn't even make sense to apply a model. And also, you shouldn't even apply this intervention because it doesn't make it, it's not, it doesn't, the cost is too high for the intervention. In the lower right-hand corner, this is a space, again, where you shouldn't bother with an algorithm. The intervention is so cheap, and the cost of the event is so high that it just makes sense to apply the intervention to everyone. Don't even bother with a model. And then this space in the middle, where with the heat map, that's the area where there's a benefit, there's a net benefit to actually applying a model to decide who gets the intervention and who doesn't get the intervention. So this doesn't just apply to healthcare. You could apply this to this type of decision theory to any type of any type of problem where you're deciding, should we apply a machine learning model here or not? And finally, another thing that we've discovered working with clinicians in healthcare is oftentimes they come to us and they say, hey, Mike, can you predict this thing for me so that we can prevent it? But they haven't really thought through, okay, once my team creates a model for them, what are they going to do with this thing, and how are they going to use that to improve patient outcomes? So and also, like, by the way, what is the outcome that they're actually going to measure so that they know that they've improved things? So let's talk through this for a particular problem that my team has worked on. So many patients receive palliative care too close to their last days, and this delayed delivery undermines the full utility of the service for patients in need. So palliative care is a type of service that is provided to patients, both often cancer patients who might need some help with pain medications or those types of things, but also just patients who are nearing their end of life, and helping to make sure that the healthcare system as a whole understands what are the patient's needs and that those needs are being met. So again, sort of like following this Mad Lib framework that our team has come up with, we would say, if I knew which patients have the most serious life-limiting illness, I would make sure they receive palliative care to ensure the care team understands their goals. So we actually did apply this framework to this Palliative Connect project, as we call it, and we developed a dashboard for the team that allowed them to go through the patients sorted by their risk of mortality in the next 6 months, and they were able to go through that list and make sure that the patients near the top of the list were getting palliative care. So they actually changed the approach that is traditionally taken. Traditionally, a doctor would call for a palliative care consult based on the needs that they see for the patient, and we sort of like flipped it on its head. In this case, the palliative care team was actually calling the doctors for these patients and asking them, do you feel, would it be all right for us to do a palliative care consult for this patient? Do you feel that it would be appropriate? And this is very much an airbag problem, because even though we're predicting the patient's mortality, we're not actually trying to prevent the patient from dying necessarily. We're trying to make sure that their palliative care needs are met. So what would the Mad Lib be for the radiology example? I don't know. Maybe if I could speed up radiology results, I could get patients out of the emergency room quicker to lower costs and improve patient happiness. I'm not sure, but that's something that I think you would want to ask when approaching that problem. So
what's the for your last example? What would you consider to be the measurable aspect of that?
Well, there's like standard ways of like measuring patient happiness, but also if it's purely cost that you're looking at, you could look at the cost of the patients in the emergency room. So.
But the palliative care example.
Oh, the palliative care example.
When you guys did that, how are you measuring?
So we measured a lot of different outcomes. Talk to me after the talk. I'm just like drawing a blank for a second. Yeah.
Thank you.
So let's talk briefly about like where I hope that the future of healthcare, data science and healthcare is going. So this is actually a paper that was released in the New England Journal of Medicine recently by some collaborators of ours, and they talked about creating a patient feed for your patients. And so they talked about a study that they did where residents subscribed to push notifications and for their patients, medication expirations, and they found that doses of antibiotics that were missed were cut by 1/3. So in this idea of like almost like a Twitter for patients, they sort of frame it as rather than the clinician having to remember to check the medical record for their patients, the medical record's kind of coming to them and informing them that they need to take some action. There's also been a lot of work around coming up with better sensors for patients, smaller sensors and cheaper sensors. So this is a sensor that measures blood pressure. I believe it's actually placed on the jugular, and it's as you can see a very small sensor. And one big issue that we have with healthcare data right now is that a lot of it is very biased. Labs are only ordered are often only ordered when a doctor thinks there might be a specific problem, and similarly. A lot of the data is entered into the health record manually. Cheap sensors would definitely potentially help with this problem, because if they can just apply these cheap sensors to all patients and maybe even people in the outpatient setting, then you're dealing with a lot of that collection bias. And then finally, there was this other article that talked about how AI will be applied in healthcare. They talked about assisting in monotonous tasks, treatment design, mining medical records, and AI chatbots. But I personally, and I think a lot of doctors feel this way, hope that AI in healthcare will be used to help the doctor spend less time in front of a computer, typing into a computer, and actually spending more time working with their patients. I can't remember where I heard this, but recently was someone had mentioned that the types of jobs that won't be automated are the types of jobs that require empathy, and they talked specifically about doctors being one of these cases. So hopefully the doctors will be able to spend more of their time applying their empathy and less of their time entering data into a computer. And if you didn't get anything else out of this talk, I hope you walk away from this talk with understanding that algorithms don't heal people, people do. And thank you. Do we have time for questions? Yeah. Okay.
Good talk.
Thank you.
Given that doctors are not trained in math, when you call them up, what kind of data do you give them to help them make this decision?
Sure. I would say it varies a lot from project to project, but oftentimes I find that one easier way to kind of like present, for example, model performance to doctors is to say, if you took this action on X percentage of the patient population, what would the performance be? Like how many of the sort of positive cases would you catch versus just like a random coin flip, or versus what you're doing now? So that's like a nice kind of like simple way to frame things. But it depends on the sophistication of like who you're working with, I would say.
Go over here and then back there.
Hey, thank you for your presentation. So you mentioned calculating the net benefits, and you put in a really nice visualization from the confusion matrix. So I wonder, in that calculation, what do you think of potentially administering care to a patient that doesn't need it, and ultimately resulting in some kind of damage with that? How do you put those things in the calculations?
Sure. So those cost calculations aren't necessarily like taking into account all the costs. You can model those costs, however, like the complexity of how you model those costs, you can make them as complex as you need for your particular application. So for my particular application, maybe there's the clinical team thinks there's very small or no cost to applying that particular intervention to a patient who doesn't need it. Certainly there's cases where that's not true, so you would want to just include that in your cost calculations.
But the clinic team actually gives you the mathematical cost of.
You have to talk. You have to talk through it, and there's it's never an exact science, but the point is it's a lot better than just looking at an AUC and saying, oh yeah, that's a good model, let's deploy that, right? So it kind of helps you get closer to what's the real cost benefit to deploying this model to the system.
Yeah.
Thanks.
Hi. How do you think you go about closing like the hype gap in terms of like the initial first slides that you showed, the hype gap, or it reminds me a lot of like the reproducibility problem between sort of academia and, let's just call them practitioners?
Well, certainly having people out there who are, trying to like our team, who are trying to prospectively apply these techniques I think is helpful. Having, actual examples of real-world applications is going to be helpful for helping to close that gap, I think. Yeah.
We had someone over here. All right. Sorry.
He actually kind of asked my question, but I'll follow up with another one. In your experience then working with the clinicians that you do, are you seeing more skepticism, or how are teams reacting to the stuff that you're doing, given some of the quote-unquote failures that have recently been publicized?
Well, I mean, I think doctors in general are very skeptical, but I think for good reasons. It's their licenses that are on the line. It's their patients who are on the line. So I think it's a really high bar as far as like doctor skepticism goes, but and I think the way around that is to sort of prove through rigorous application of experimentation that these models can be beneficial. So you have to find the right partners on the clinical side that are willing to kind of go through that process with you and hope for the best, I guess.
Hey, great talking. Could you comment a little bit about data privacy and trying to acquire data, especially in the whole NumFOCUS kind of thing where there's open source development and how difficult it is to kind of get this data? Could you elaborate on how hard it is to get that data and how hard it is to share and how it's kind of changed the last few years? Sure.
I mean, there are increasingly more and more open data sets, like the X-ray data set, for example, is an open data set. My team, being embedded in the healthcare system, we have access to the data for our patients, and as long as So that, it's obviously easier for us than, I don't know what your background is, but like if you're like a researcher, it's obviously a lot harder to gain access to data. I think it's an open question. There are a lot of issues around sort of anonymizing this healthcare data and finding techniques for good techniques for anonymizing healthcare data. If you have any experience or any ideas around this, I'd be happy to kind of talk to you about it afterwards.
So I realize that this question is probably a future talk in itself, but my experience is that clinicians are rightfully very skeptical of any model output, especially if it can't be explained well to them exactly sort of like what the inferences it's drawing is. And so how have you sort of tried to reconcile the fact that the actual cool stuff, especially on the hospital side, is using methods that are extremely difficult to see what they're doing? It's not a logit regression.
Yeah, it's interesting. In our experience, oftentimes the doctors who are directly collaborating with us, the ones who are working to develop the models, they're far more interested in interpretability than like the day-to-day clinicians who actually would have to use those types of models. In our experience anyway, the day-to-day clinicians who have to utilize these models, they just want to know, is this a good model, and should we trust it? And where's the paper that says, by the way, when you apply this model in this clinical setting, it has this benefit? But I do believe that interpretability is important. I think it's kind of at least in my mind and in my experience, is kind of an open question how important interpretability is.
We have time for one more question.
So you mentioned interpretability. What algorithms are you using mostly? I assume you're not using a lot of neural networks?
No. So it varies from project to project, anywhere from logistic regression to gradient boosting models. We've discussed using neural networks for some projects, but we haven't actually found an appropriate application for them yet. All right, thank you.
Oh, yeah, thanks.